Hello everyone, happy morning, a very good morning. A quick nod whether the audio visual is all good. Sorry for the delay, actually was facing some audio issue. Is the audio visual good? All right, great, amazing. So I just did it here. So I hope and I believe all of you are doing well and you are done with ANS pharmacology. And I totally understand that ANS pharmacology is a very, very confusing topic in pharmacology. So yesterday we tried to complete the parasympathetic system, that's the cholinergic and the anticholinergic. I hope all of you have learned the tricks of ANS pharmacology. We started with the adrenergic system, but then we are left with some part of it and the entire anti-adrenergic system also. So we will be doing it today at 7 p.m. I'll be sharing the link on the Telegram group. So ANS pharmacology at 7 p.m. is what is the plan. Okay. And in this session, we are going to simplify the topic of glaucoma drugs. It's a very, very important topic in pharmacology. It will help you in ophthalmology as well. So basically, it's an integration of pharmac and ophthal. And I'll try to tell you all the tricks that will help you to remember which drug acts by which mechanism in glaucoma and what is the side effect of a particular group of drug which is used in glaucoma. So both of these are important and frequently asked, right? So no audio, I think the way the audio is good. Okay. Okay. I'm sure all of you know about Iconic, which is Unacademy with Prep Ladder together. And till 22nd, right, only for the next 3 to 4 days is where we have this offer of 20% off. Like normally, if you subscribe, you get 10% off, but till 22nd, you are getting double the discount, that is 20% off. And you can use my code Dr. Nikita while you are subscribing, or any other code you have, you can use while subscribing to get the 20% off while subscription till 22nd of July. We are also starting with INICT dedicated batch on July 21st. Specific coverage of the last 3 year topics and questions that have been covered so that you get an idea that which topics are important in which subject, and you have the best of the educators, the respective subject educators who will be dealing with radiology, and I'll be dealing with their respective subject, and I'll be dealing with radiology in this particular batch. Also, we have the FMG batch going on, and we also have the test and discussion batch, live MCQ discussion also going on. So make the best of it. If you want only test series, question practice, like I said, practice questions from multiple platforms, you can take light subscription as well. All right. So having said that, let's start with our today's session that is about glaucoma. Now, talking about glaucoma, let me give you a quick, let me give you a quick overview and then we'll go into the details also. See, what is glaucoma basically? First, let's understand the concepts that what is glaucoma. Glaucoma basically in simple terms means that there is increased intraocular pressure. The pressure in the eye is high. The pressure is increased. Now, why the pressure is increased? Because there is increased quantity of aqueous humor in the eye, right? From where this aqueous humor comes? Aqueous humor basically is secreted by the ciliary processes, okay? By the ciliary process, and it is basically coming from the plasma. Okay, it is coming from the plasma. So basically, you have the blood flowing, and from there, this aqueous humor is being produced. Now, tell me that which is the major process which is responsible for aqueous humor production? Is it the diffusion? Is it the ultrafiltration? Or is it active secretion? What is the major contributor to the production of aqueous humor? Is it diffusion? Is it ultrafiltration? Or it is active secretion? Okay, so the major contributor is, active secretion. Okay, active secretion is the major contributor, about 70%. So then this is, basically coming from the plasma. It is active secretion, which is the major one. Now after that, this aqueous humor basically getting recycled, and where it is absorbed, what is the outflow? So we have two outflows, that is the trabecular outflow, and we have the uveoscleral outflow. Okay, trabecular and the uveoscleral outflow. Now majority of the outflow is 90% is via the trabecular outflow, 10% is uveoscleral outflow, right? So this is how the aqueous humor is flowing. Remember that aqueous humor is secreted by the non-pigmented epithelium pars placket of ciliary body. So basically the site of production is ciliary process. It is derived from the plasma, and major is active secretion, 70%. Trabecular outflow is the major outflow. Let's have a look at this diagram. Okay, let's have a look at this diagram basically. So here you have ciliary body, जहां से aqueous humor आ रहा है. The aqueous humor is flowing like this, the aqueous humor is flowing like this, and then the outflow is either through the trabeculae, 90%, or it is the uveoscleral outflow, right? The uveoscleral outflow, which is 10%. Okay, so you can see that this is how the outflow is happening. Okay, this is how the outflow is happening. So if there is something which is causing a block here, iris getting stuck to the lens, the aqueous humor will not be able to flow. So it is important to keep this open as well. Okay, remember that point as well. Now, going to the next one. So which are the drugs basically which are used in glaucoma, and what is the mechanism of action? So basically our aim of treatment in glaucoma is to decrease the quantity of the aqueous humor, because that is increasing the pressure. So either we decrease the aqueous humor by decreasing the production, by increasing the outflow. Okay, by decreasing the production or by increasing the outflow. Now, which are the drugs which act by decreasing the production? Which are the drugs? Now, this is very, very important. Like I mentioned, that which drug acts by which mechanism? Decrease production, remember A, B, C. Okay, A, B, C. Even in A, B, C, remember it is A, B, B, and it is C. So AA basically means it is alpha agonist, it is beta blocker, and C stands for carbonic anhydrase inhibitor. Okay, carbonic anhydrase inhibitor. So remember, latanoprost यहाँ नहीं आता है. Okay, latanoprost, dipivefrin do not come here. You have alpha agonist, we have beta blockers, and we have carbonic anhydrase inhibitors. Okay, carbonic anhydrase inhibitors. Now here you have an increased outflow. Even in outflow we said that there is trabecular outflow, right? Even in the outflow basically we have trabecular outflow and we have uveoscleral outflow. Which drug acts by increasing the trabecular outflow and which drug acts by increasing the uveoscleral outflow? So trabecular outflow, remember, basically is myotics. How do you remember that? So remember that myotics, when you write myotics, IOT, that is increase outflow through the trabeculae. Okay, increase outflow through the trabeculae. So myotics के spelling में basically increase outflow through the trabeculae. Now which are the myotics drug? Yesterday from ANS pharmacology, myotics means pupillary constriction. What causes the pupillary constriction? Is it parasympathetic or sympathetic? Constriction, right? The pupillary constriction is cholinergic drugs. Cholinergic drugs, that is parasympathetic drugs like pilocarpine, right? Like pilocarpine. We saw yesterday LOCCOL. These are cholinergic. So pilocarpine, myotics, increase outflow through the trabeculae. Increase uveoscleral outflow is your PGF2 alpha drugs. Okay, the PGF2 alpha. Remember, F for flow. Okay, basically they increase the outflow. They do not act on the production and they act by increasing the uveoscleral outflow. Like you have latanoprost. So the prost wale drugs हैं, those are the PGF2 alpha and they act by increasing the uveoscleral outflow. Right? Clear with everyone? So let's have a look at this one. So decreased production is ABC, or you can remember CAP, alpha agonist, beta blockers, carbonic anhydrase inhibitors. Trabecular outflow, increased outflow trabeculae is myotics. PGF2 alpha is uveoscleral outflow. Very important question. Which drug acts by increasing the uveoscleral outflow? PGF2 alpha. Okay. Now talking about angle closure glaucoma, okay, and how myotics play a very important role in angle closure glaucoma. So remember that in angle closure glaucoma, what is contraindicated? Yesterday we had seen this in ANS pharmacology. So when you have the angle closure glaucoma, you do not want the mydriasis to happen, right? You do not want the mydriasis is contraindicated in angle closure glaucoma. The mydriasis will block the angle further, okay? It will not allow the flow of the aqueous humor, okay? It will not allow the flow of the aqueous humor. So remember that when you have mydriasis, this is also blocked. It increases the pressure. When you do meiosis, this is at least open. Okay. So that's the reason, in your questions, you will have this scenario that a person goes to a cinema theater and suddenly develops pain, redness in the eye. So that is pointing basically towards angle closure glaucoma. So whenever you have dim light precipitating pain and redness in the eye, think of angle closure glaucoma. Why the dim light? Because basically in dim light there is mydriasis. Okay, so that will increase the pressure. So therefore in angle closure glaucoma in treatment we give myotics. Okay, remember this point. Myotics are a definitive treatment here, definitive drug in basically angle closure glaucoma. Okay. Look at this quick revision here of the mechanism of action. If I ask you the question, which glaucoma drug can be given orally? Which glaucoma drug can be given orally? What do you think would be the answer to that? Is it pilocarpine? Is it timolol? Is it acetazolamide? Is it latanoprost? Which one can be given orally in glaucoma? Right. It is acetazolamide, right? Remember, acetazolamide is given orally. It is a carbonic anhydrase inhibitor that's given oral. Remember, these carbonic anhydrase inhibitors, they can be given oral, they can be given topical. Acetazolamide can be given oral only. It cannot be given topically. Topically, carbonic anhydrase inhibitor is उसके बाकी भाई बहन, that is dorzolamide, brinzolamide, वो सब हम दे सकते हैं topical. Acetazolamide, remember, cannot be given topically. Okay, so look at all the drugs: beta blockers topical, alpha topical, cholinergic topical, prostaglandin topical. But carbonic anhydrase inhibitors can be topical and systemic. Out of that, acetazolamide is oral. Dorzolamide, brinzolamide are topical. Right? How do the drugs act? Decrease the production. Right? Decrease the production. ABC. Okay. Aqueous outflow, pilocarpine, myotics. This increases the trabecular outflow. Prostaglandin increases the uveoscleral outflow. Alpha agonist acting on both outflow and production. Okay. So coming to another revision, drugs used in glaucoma, decreasing the production, increasing the outflow. Production is A, B, C. Alpha agonist, brimonidine, apraclonidine. Right, we'll see in ANS pharmacology also today. जो डाई वाले ड्रग्स है बेसिकली ये अल्फा 2 है. क्लोनिडीन, ब्रिमोनिडीन, डाई वाले इज अल्फा 2 एगोनिस्ट. बीटा ब्लॉकर्स, कार्डियोसेलेक्टिव, नॉन सेलेक्टिव. Betaxolol, timolol is non-selective. Remember, the beta blockers which come after alphabet M, they are generally non-selective. Exceptions are of course there like nebivolol. Okay. Carbonic anhydrase inhibitors, acetazolamide oral, this can be given topical also. Trabecular outflow, myotics, pilocarpine, physostigmine. Remember physostigmine, It is your acetylcholine esterase inhibitor. So increases acetylcholine, so basically cholinergic. Alpha 2 agonist, which increases the trabecular outflow. You have dipivefrin, which is prodrug for epinephrine. Uveoscleral is latanoprost, bimatoprost, PGF2 alpha. Okay. Now tell me, what is the drug of choice in the open angle glaucoma? What is the drug of choice in open angle glaucoma? Is it acetazolamide? Is it pilocarpine? Is it latanoprost? Is it beta blockers? What is the drug of choice in open angle glaucoma? Right, it is latanoprost. Okay, the PGF2 alpha group of drugs. Previously, it was beta blockers. Now it is latanoprost, that is PGF2 alpha. See, when the angle is open, that means that there is some problem with the trabecular outflow. The majority, 90% happening to trabecular, is a problem there. So we try to increase the outflow through the other route, that is the uveoscleral outflow. Right, we try to increase its use. So we use PGF2 alpha, that is latanoprost. And if the question is, what is the definitive treatment or surgery? What surgery do we do in open angle glaucoma? Is it iridotomy, iridectomy, trabeculectomy, trabeculoplasty? So it's all based on the experiments that are done, that which drug is found to be more effective, right? The RCTs which tell you that which is more effective. Is it iridotomy, iridectomy, trabeculectomy, trabeculoplasty? What is the surgery that we do in open angle glaucoma? Next. It is trabeculoplasty. Okay, it is trabeculoplasty that is done. Because the angle is open, there is no problem anywhere. Angle वगैरह सब open है. So probably the problem is in the trabecular meshwork itself. So we try to do उसका plastic surgery जैसे, we try to modify that. So we do trabeculoplasty. Please remember that point. Okay, we do trabeculoplasty. Okay, in angle closure glaucoma, the first drug is either acetazolamide or mannitol, right? Basically to decrease the production of aqueous humor. What is the definitive drug that we give in angle closure glaucoma? The myotics, right? The myotics play a very important role in the angle closure glaucoma. Okay, and what is the definitive treatment? If the angle is closed, basically what do we do is we create a hole in the iris through which the aqueous humor can flow. Okay, so basically we do iridotomy, or we do iridectomy, or we can do trabeculectomy, not trabeculoplasty. Okay, and the other eye also needs the surgery. Okay, an angle closure glaucoma. So remember, we do iridotomy ताकि हम bypass route बना रहे for the aqueous humor to flow. Okay. Now coming to some new drugs basically in glaucoma. Ropresa, ripasudil. Okay. So remember this Ropresa, Ro is Rho kinase inhibitor. Okay, like you have fasudil, which is used in angina. You must have read in CVS pharmacology, Rho kinase inhibitor. Ripasudil, like fasudil, this is also Rho kinase inhibitor. So remember, these are used in glaucoma. Abodenosone is basically your adenosine wala drug. Latanoprostin is like latanoprost, but along with that, it is latanoprostin bunod. Remember, bunod is basically nitric oxide donor. Okay, nitric oxide donor. So both of these basically increase the uveoscleral outflow. Okay, the uveoscleral outflow. So remember, like trabecular pe act karne wala, adenosine wala, and it is increasing the uveoscleral. Natarsodil is also another drug, the Rho kinase inhibitor. That is natarsodil is for glaucoma. All right. Now coming to, so this was about the mechanism of action, and I hope everybody is clear. Easy, decrease production, increase outflow, trabecular and uveoscleral. Right. You have ABC, you have myotics, and you have PGF2 alpha. Acetazolamide is given orally only. Okay. Now coming to the side effects of these drugs. what are the side effects of these drugs? ABC से start करते हैं अगर ABC, that is your alpha 2 agonist. Which were the alpha 2 agonist? Apraclonidine and brimonidine. Tell me, what is the side effect that we see with apraclonidine? What side effect do we see with apraclonidine? When I write apraclonidine, okay, when I'm writing apraclonidine, so basically remember the CON and you have the other one, that is LID. Okay, the CON and the LID. What does that tell you? So remember, CON is basically conjunctivitis. What conjunctivitis it causes? Follicular conjunctivitis. Okay, follicular conjunctivitis. Another one, LID, is basically lid retraction. Very, very important. Okay, lid retraction, apraclonidine. Okay, so lid retraction and conjunctivitis, that is follicular. Brain depression is a side effect which is seen with. The depression is the side effect which is seen with brimonidine. Okay, remember now brimonidine. Brimonidine is BRI. Okay, brimonidine. So it is basically inhibiting the brain. BRI, remember, is brain inhibition. That is brain depression. So that is why it is contraindicated in children. Okay, remember, that is why it is contraindicated in children. So brain depression karke, it can lead to apnea. So it is contraindicated in children. Okay. So ये हो गया alpha 2 agonist वाले drugs. Then you have beta blockers. What is the side effect seen with beta blockers? Beta blockers, remember the degree BDS. Okay, BDS. So what all does it do? It does blepharoconjunctivitis. D for dry eye. Dry eye means keratoconjunctivitis sicca. And S for superficial punctate keratitis. So basically remember, BDS is beta blockers, BDS, blepharo, dry eye and superficial punctate keratitis. NLD obstruction does not come here. Nasolacrimal duct obstruction is a side effect seen with myotics. I'll come to that. Okay, so remember B for BDS. Then you have the next ABC में carbonic anhydrase inhibitors, like you have acetazolamide. Very, very important. Acetazolamide, does it cause metabolic acidosis or it causes metabolic alkalosis? Does it cause metabolic acidosis or metabolic alkalosis? Remember, acetazolamide is acid, so it causes metabolic acidosis. We have discussed this many times that it causes RTA, renal tubular acidosis type 2. It is the brand name like is Dimox. So di matlab 2. It causes RTA type 2. So it is acidosis. Second, this is the group of drug which is contraindicated if a patient has sulfur allergy. Okay, so remember, it is contraindicated in sulfur allergy. So metabolic acidosis karega or sulfur allergy mein we will not use. So we are done with the first group of drugs, ABC, that is alpha agonist, beta blockers and carbonic anhydrase inhibitors. Now coming to what is the side effect seen with myotics. Myotics, increase outflow trabecular, that is the mechanism of action. Myotics is MI, that is my eye is entirely affected from the front to the back. You start from outside, right? So you have the brow ache, nasolacrimal duct obstruction, there is cataract, there is iris cyst, retinal detachment, everything, myopia. Remember, myotics, MIO, they cause myopia. Okay, myopia also is a side effect seen with myotics. So remember, they cause all the side effects, my eye, everything from outside to inside. NLD obstruction, we have the brow ache, right? Then आपका iris is also affected, iris cysts are seen, lens is also affected, cataract, and the retina is also affected, that is retinal detachment, and very important, we have myopia also. Okay, myopia also. So basically all the parts of the eyes are affected. So remember, this is myotics. Okay, this is about myotics. Now coming to uveoscleral outflow wala, that is PGF2 alpha. What is the side effect seen with PGF2 alpha? What is the side effect seen with PGF2 alpha? Remember, you can remember this FG, this is EFGHI. When I say ABCD, EFGHI, so FG is basically the group of drug that is there. What group? It is PGF, right? PGF. So F and G is done. उसका side effect होता है E for edema. What edema? Cystoid macular edema. Okay, cystoid macular edema. H for hypertrichosis. So basically the eyelashes overgrowing, hypertrichosis. I for iris pigmentation. Remember, this is not conjunctival pigmentation. It is iris pigmentation, that is heterochromia iridis. Okay, so that is what is seen with PGF2 alpha. Remember, cystoid macular edema, a very, very important question. Hypertrichosis, iris pigmentation, all of these are important MCQs and questions which are asked. EFGHI, edema, hypertrichosis, right? Remember edema, then you have hypertrichosis, and you have iris pigmentation with PGF2 alpha. Okay, with PGF2 alpha. Now the last group that is left, which is the prodrug for epinephrine, that is dipivefrin. Okay, that is dipivefrin. Remember, dipivefrin is dip, and imagine this image here. So you have the black bean dip. That is the black dip. So remember, dipivefrin, dip is the dipivefrin which causes black pigmentation of the conjunctiva. Remember, this is the black pigmentation. This is the black dip which causes black pigmentation of conjunctiva, not of the iris. Okay, it is the black pigmentation of the conjunctiva, not of the iris. Okay, for iris pigmentation, it is PGF2 alpha. Okay, for conjunctival black, it is dipivefrin. Okay, it is dipivefrin. So yes, I think we are done with the side effects also. Let's have a quick review of all the important side effects. Which drug causes lid retraction? I hope this is clear with everyone. Let's quickly revise the tricks on how to remember that. Which drug causes lid retraction? It is apraclonidine, right? Lid retraction is apraclonidine. Which drug causes apnea, brain depression? It is brimonidine. Okay, it is brimonidine. Next one, okay. Just give me a minute. Next one is conjunctivitis. In conjunctivitis, you have follicular conjunctivitis and you have blepharoconjunctivitis. Follicular conjunctivitis is apraclonidine, right? The CON. Blepharoconjunctivitis is BB, that is beta blocker. Okay, that is beta blocker. Then you have pigmentation, right? In the pigmentation, iris pigmentation, conjunctiva pigmentation. Iris pigmentation is EGF wala, that is PGF2 alpha. Conjunctival, the black conjunctiva, this is seen with dipivefrin. Okay, this is seen with dipivefrin is the black dip. Okay. Which one causes metabolic acidosis? Acetazolamide, that is carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. Which one causes myopia? Myopia is a side effect seen with myopia is myotics. Okay, myopia is myotics. Which one causes NLD stenosis obstruction? My eye entirely affected, so it is myotics. Okay, it is myotics. Which one causes eyelash overgrowth? That is hypertrichosis. Hypertrichosis is a side effect seen with, it is PGF2 alpha, EFGHI, right? Which one causes cystoid macular edema? Again, PGF2 alpha. Okay, PGF2 alpha. So now tell me, that if I ask you some question from ophthalm, cystoid macular edema is what appearance? On your FFA fluorescent angiography, what appearance do we get in cystoid macular edema? Yes, so basically I'm telling you to integrate the two mnemonics here. What appearance do we see? Is it the mushroom, umbrella, smokestack, flower petal appearance? What appearance is seen? See, it's not the smokestack. Understand the word terminology itself. Smokestack is like the smoke, the contrast is coming out. It is what one gives your smokestack appearance? The central serous retinopathy, CSR, from where the fluid is going out. It is flower petal appearance. Okay, it is flower petal appearance. Now, how do you remember this is? So, remember that cystoid macular edema. So, edema is equal to fluid, and this fluid is equal to flower. Okay, fluid is equal to flower. So, basically remember that fluid, that is edema, that gives the fluid is flower petal appearance. Okay, so another very important question. Remember, it is the flower petal appearance which is seen. Okay, it is the flower petal appearance, PGF2 alpha basically. Okay, that's your PGF2 alpha. All right. And what surgery did we say for primary open angle glaucoma? What surgery? The angle is open, so flow में कोई problem नहीं है. It's the absorption that is getting affected. The trabecular meshwork needs to undergo a plastic surgery. So remember, it is trabeculoplasty. Okay, so remember it is trabeculoplasty, which is done in primary open angle glaucoma. In angle closure glaucoma, we do iridotomy, iridectomy, or trabeculectomy. The fellow eye also needs to be cured, to be treated. Okay, preventive surgery needs to be done there as well. All right. So yes, this was about the glaucoma drugs. Everybody is clear with this? Any queries here? Everybody is clear with the mechanism of action? Right, ABC decreases the production. Trabecular outflow is myotics. UVS scleral outflow is PGF2 alpha. That's the mechanism of action main. Right, easy. Then you have the side effects. That each drugs we have discussed the side effects. Lead retraction से मुझे दूसरा mnemonic बताओ कि what is that sign in Graves ophthalmopathy where you have lead retraction? That sign in Graves ophthalmopathy where you have lead retraction is called as what sign? Is it your Mobius sign? Is it Van Griffiths? It is Griffith? It is Dalrymple? Steelwog? What sign is it? Yes, doctor's diary. This is enough for glaucoma drugs. आप जाके देखोगे तो नोट्स में इतना ही दिया है, जस्ट दैट आई मेड इट कंसाइज एंड आई टोल्ड यू ऑल द ट्रिक्स. नहीं, वॉन ग्रिफी नहीं है, वॉन नहीं, स्टील वॉक भी नहीं है. यस, मिस्ड, करेक्ट. अभी देखो इसका है, दिस इज डालरिम्पल साइन. ओके, दैट इज योर डालरिम्पल साइन. That is your Dalrymple sign, which is lid retraction wala. Okay, the Dalrymple sign is basically lid retraction. The trick to remember is in Dalrymple sign, okay, you have LR, that is the lid retraction. Okay, that is the lid retraction. What is Van Griffiths? What is Van Griffiths sign? Griffiths is grief. When a person is in grief, sad, we tend to look down. Basically, Van Griffiths is when the patient looks down, the upper eyelid is lagging behind. Okay, the upper eyelid is lagging behind. That is the Van Griffiths. Okay, that is the Van Griffiths sign. Okay, so that's already a video that I've put out on the mnemonics for the grave signs, ophthalmopathy mein sign. So please watch that video. Okay, please watch that video. Okay. So yes, that was for the today's session in glaucoma drugs. Try to just make one-page notes out of it. solve the MCQs and make it consolidated, compile at one place, so that's all you have to revise next time for the glaucoma drugs. Okay, and a quick reminder, I hope all of you remember, for the offer which is ongoing till 22nd itself, we have that is 20% off, and we'll be meeting again today, basically at 7 p.m. for the remaining part of ANS pharmacology. I'll be sharing the link on the Telegram group. Okay, thank you so much everyone. Have a great productive day and goodbye. Take care. Keep studying, keep revising.